Well, good morning, everyone. It's 9 o'clock, so I think we'll go ahead and get started with our conference this morning. My name is Jim Capretta. I want to welcome you to the American Enterprise Institute, including those who may be watching this conference online. I think it's going to be a very informative morning. I want to also join with my colleague Joe Antos and welcome our distinguished group of speakers this morning. We're very pleased they were able to make time to participate in the conversation. Our topic this morning is delivery system reform, which is not always an obvious descriptor of what may be the most important public policy issue facing the country. Rapidly rising healthcare costs is a major reason for the federal government's projections showing that there are going to be very large deficits in the near term and over the long term. American families are also feeling overburdened by healthcare expenses, obviously state and local governments as well. The only way to slow the pace of rising costs without compromising quality or making people just wait for their care is by increasing the productivity of what is called the delivery system. The nation's vast network of inpatient facilities, physician practices, outpatient clinics, labs, and much more. Put another way, we need that network of care delivery to become ever more efficient over time. That, by the way, is the only way to make a real dent in premiums, too. Most proposals under consideration in Congress for revamping the insurance market would simply shift the burden of premium payments from one group to another without lowering the overall cost equation. Our schedule for this morning is as follows. We will hear first from our initial speaker, Brent James, Dr. Brent James, who I will introduce in a moment. Following his remarks, we will then turn to our panel to extend the conversation and hear from some additional experts who are here today. We will conclude with some additional time for questions at the end of the program from the audience. Now to our first speaker. Dr. Brent James is known internationally for his leadership role in driving continuous improvement in the quality and efficiency of the care provided to patients. Our topic today, again, is delivery system reform. But what does that actually mean in practice in a real institution? There's no one better than Dr. James to help start that conversation here this morning about what it actually means in practice. Dr. James is a physician, trained in oncology and surgery. He moved to Utah in 1986 and eventually found his way to Intermountain Healthcare, one of the nation's most respected integrated care systems, where he served for more than 2 decades as Chief Quality Officer and as Executive Director of Intermountain's Institute for Healthcare Delivery Research. He's recently retired, so he can really speak his mind today. Dr. James has trained more than 5,000 physicians and medical professionals through his advanced training program in clinical practice. He serves on the National Academy of Medicine and has faculty appointments at Stanford University, Harvard, the University of Utah School of Medicine, and the School of Public Health at the University of Sydney in Australia. Perhaps the highest compliment that can be paid to Dr. James is that his efforts have changed clinical practice for the better for literally thousands and thousands of patients. So Dr. James, thank you for coming today.
Thanks very much, and good morning. It's a delight to be here. You did ask that I comment on the ACA. This is superficial, to say the least. But just to kick off the discussion, I don't plan to dwell on it in any way. I divided it into the good, the bad, and frankly, that doesn't matter very much. The good, I think that elimination of underwriting for health insurance is a big step forward. Does away with job lock. It means that people really have some access to care when they most need it. More people with health insurance, at least for us when I was working for Intermountain, made very little difference, interestingly enough. We provided the care anyway. Improved our finances a small amount, not a large amount. Truth is, we have a large insurance company. Intermountain Select Health was the largest commercial insurer in the area, and we ran it all through Select Health, and holy cow, we took a bath on the federal programs initially, but about a break even in terms of net spend. The bad, I'm deeply troubled by the high deductibles in the current ACA plans. It means that much of the ACA insurance programs, the really major medical, the families that we're asking to buy those plans or subsidizing to buy them don't have $6,200 in out-of-pocket cash to cover the initial deductibles. So when is insurance not insurance? Well, when you apply that kind of a plan to that kind of a population, I think it belies its underlying philosophy. I believe that adverse risk selection is quite real, having watched it at the front lines. It has to do with not strong enough incentives to cause the healthy to enroll. And at the same time, the community rating rates of 1 to 3 are just plain too low in terms of a fair financial market. I think that's the real challenge that ACA faces moving ahead. It'll really struggle. And to the extent that insurance premiums rise, the federal government's share of that cost will continue to rise as well. But it will make it more and more difficult to have a true insurance risk pool moving ahead. Other things just didn't matter. I know they're politically popular, but the extended coverage for children under their parents' plans till they were 26 years of age, meh, who really cares along the way? And then the coverage mandates, some of the coverage mandates included in the plan, I guess they were politically popular, but medically many of them make no sense at all. They don't buy benefit for the amount that you spend. Admittedly superficial. There's a lot more we could say about this, but with that, let's get to the really fun issues. I need to do 4 things. And number 1, I need some framing issues just to get a little bit of background in place. 3 major areas. Sources of health. The idea of patient-centered care, I'd like to define that a bit. And then something in quality improvement that's called move upstream strategies. That will lead to a fast discussion on variation in care delivery. We can then extend variation literature, a little bit of a breakout, into opportunities for better care, particularly more productive care, more efficient care along the way. That frames waste models. My real purpose is to talk about waste in care delivery today and give us some sense of how much of it there is and what opportunities look like. The last bit we need to talk about is aligning financial incentives within the system. So, basic outline. Let's just jump into it. Number 1 question, what's the primary thing that determines a person's health? Turns out there's a fairly rich literature around this. The number 1 thing, about 40% of a person's health, is their own behaviors. Number 1, tobacco. Number 2, obesity. It just moved into number 2, supplanting number 3, alcohol and other recreational drugs. Number 4, sexually transmitted disease, including AIDS. Number 5, unwed pregnancy. Pregnancy without an adequate social support network. We used to call it teenage pregnancy, but that's shifted now, especially in poorer populations. I believe in some ethnic subpopulations, 70% unwed pregnancy rates. Most of the harm coming in the life of the neonate, not surprisingly. Number 6, suicide, accidents, and violence, particularly among young men. AMA argued some years ago that those 6 account for about half of all healthcare expenditures in the country. Very tightly linked to education level. The best predictor of healthy behaviors is your education level. There's a secondary literature that shows that you get more health benefit by investing in general education. Producing more high school graduates, more college graduates will have a bigger impact on health than investing the same money in healthcare delivery. But about 40% of your health are behaviors. About 30% genetics. The joke is how wise you were in selecting your parents. We're starting to make some scientific inroads, but still have very little to offer in this area as a health system. About 20%, that's probably a bit low, 20 to 25. Physical environment, social networks, a new and developing field of health services research and public health, control of epidemic infectious disease through immunization and sanitation. Interestingly, the care delivery system is the smallest contributor to health in the country. At best, it's about 10%. If I put on my green visor, sharpen up my pencils, get really nasty in my analysis, maybe 5%. If I run it really tightly, this massive enterprise on which we spend so much of our resources. You have to remember that the healthcare system is not mostly about health. It's mostly about caring. If you ask patients carefully, the number 1 thing they seek is a relationship with a trusted advisor. Still today, there's a reason we're called the caring professions. Define the professions across millennia in the past. And if you combine those two, the idea of health, curing, and the idea of caring, you get something I like to call rescue medicine. trying to pull people back from the brink of death at great expense and marginal success, which is one of the main reasons that we're so much more expensive than, for example, European countries. But the first idea, sources of health. I want to use that in a particular way. It has to do with probably the finest piece of work, I believe, with which my name's ever been associated. It was the Institute of Medicine's Committee on Quality of Healthcare in America. We published 2 reports to Erich Schumann that launched the patient safety effort across the country. But number 2, crossing the quality chasm was the IOM's prescription for reform. Technically, we were focused on the U.S. health system. I think it fits for almost any country. Fine piece of work in my mind. Within it, we popularized a term. It was not a new term. Don Berwick actually brought it forward. It was called patient-centered care. Now, patient-centered care, what did we mean? There are 2 different ways you can think about that, and Elliot will have something to say about one of them, I think, coming up. What we really meant, if you examine the care delivery system, it's mostly organized around physicians. We actually queue up patients to wait for the important physician's time. The second major organizing principle is technologies, that big proton beam accelerator or an MRI scanner. Queue them up for use of the technologies. Number 3 is facilities, buildings. Well, what if, instead of organizing around physicians, technologies, and facilities, what if you organize the care around the patients instead? Now, Clay Christensen at Harvard, a name you should know, probably know, talks about the job to be done. He asks, what is the job to be done in healthcare delivery? We help them understand what it is, but then we try to address that problem, a diagnosis, a condition, usually. Pregnancy, labor, and delivery is a condition. Most of them are disease entities, type 2 diabetes mellitus, major motor vehicle trauma, you see. They seek help for specific clinical problems or conditions. That's the job to be done. Now, if I reduce that to quality improvement language, I would call them processes of care. And that's what we really meant. I'd say it's 80 or 90% of what we meant in crossing the quality chasm as we talked about patient-centered care. What we meant was care organized around the job to be done, rather than around physicians, technologies, and facilities. You see, there's a second meaning. It's certainly not to be discounted. It's the idea that you involve patients and their view of their needs on your teams. But I think it's important that you get both. And the one that I think is sometimes overlooked at the moment is this idea of organizing around clinical conditions. Now, you can combine these 2 ideas to make a really interesting model, which is personally my very favorite for understanding population health, this new thing that we talk about called population health. What I've done here is stack the items we've been talking about. Genetics at 30% up at the top right here. I've graded out because we have little to offer. The idea, though, of the physical environment and personal health behaviors, that's population health. It's about 60% of total health and about 85% of the total health opportunity. By far the most dramatic share of opportunity lies at that level of disease prevention, screening and detection. Then, of course, when you find an actual condition, we feed it into the care delivery system, primary care, feeding specialty care, secondary care. Acute episodes treated in hospitals and emergency departments. Then, depending upon the condition, eventually to some sort of resolution. If it's pregnancy, labor, and delivery, hopefully within about 9 months. If it's diabetes mellitus, it's probably with you for the rest of your life, such as it is. So you see the idea? Within quality improvement, we talk about what we call move upstream strategies, here to the far right. Nearly always, it's dramatically more productive and efficient if you can intervene higher in the chain. And I'd like to show you some examples of that moving ahead. But I wanted the idea of sources of health tied into the job to be done, patient-centered care. It's just a way of framing the whole debate. It defines this, well, it's the core idea. Quality improvement is preventive medicine writ large. The heart of quality improvement is prevention. Move upstream strategies. Rather than waiting for something to go bad and then respond, move upstream, act before the problem arises. Preventing downstream need is the basic idea behind it. A massive productivity enhancer. Well, with that for background, the next thing, I really got my start in this way back in 1986 when I moved to Utah. I came out of the Dana-Farber Cancer Institute, mostly did randomized controlled trials of new cancer therapies. It was my real academic training, where I really find my roots. We were studying variation in care, frankly, building off work that Dr. Fisher represents fairly heavily. Jack Wenberg, Elliot Fisher does it at the Dartmouth Institute. Now, they looked at geographic variation across communities. We drove it a level deeper. What we were all doing, though, to my mind, was taking the rigorous measurement methods developed for clinical research. And for the first time in human history, we swung those tools to focus on care delivery performance. Prior to this time within the healing professions, there was a belief that if you're a highly trained physician, an expert, that it was quality because I did it. As an expert in the field, hey, I was based at Dana-Farber Cancer Institute, for heaven's sakes. You know, I had the position, I had the fame. It was quality because I did it. And then we started to measure actual patient outcomes using rigorous tools, and wow, did we ever get a surprise, to say the least. When I first came to Intermountain, it was to take what Elliot and Jack and others had done at Dartmouth and other places, it was very widespread, and push it down a layer. We wondered whether there was variation that continued down to the level of individual patients within a hospital. We developed a study design for doing it. I won't go into its detail. It was fairly rigorous. I actually personally believe, a little self-serving, that it's as good as it's ever been done. And of course, what we discovered is that when you dropped inside a facility, the level of variation actually went up a bit. We found truly massive variation. I won't go into the details except to say, well, measuring across thousands of factors for very carefully balanced cases, statistically identical cases, measuring across physicians, the smallest range of variation I ever found was about 60%. I mean, if somebody were using 10 of something to get the job done, somebody else was using 16 of the same thing to get the same outcome on the same patient, and that's the closest we ever came. The widest range we found in our 6 QUE studies, quality utilization efficiency studies, was about 560%. If somebody was using 10 of something to get the job done, somebody else was using 56. It was stunning. Oh, don't think just physicians. I've been picking on physicians a bit here. The variation levels we found in nursing were actually a bit higher. The grand champion for variation I've ever encountered in my career is physical therapy. It's not just physicians, it's endemic across the face of medicine. It's also endemic across the world. Just commenting to Elliot before we started, it's the same sort of variation that you find in Europe or in Canada or Australia or in Singapore. It ties back to the core precepts, concepts, assumptions of the healing professions more than any other single thing. Not so much to help policy as to the nature of the healing professions and how we see ourselves and how we organize our work together is the key idea with it. Just for one example, this is something called transurethral prostatectomy, of very common procedures back when we were doing this process. Very carefully balanced cases. You can make the argument they're statistically identical. This is an activity-based costing system, so it measures true cost, not some sort of charge estimate along the way. But as you can see, we had one physician to execute that care was spending $1,164 hospital dollars to get a good outcome on a standard case. Another physician, twice as much, $2,233. Same patient, same outcome, twice as much resource. It raised real questions, initially raised by the Dartmouth team. The variation was so large that it was pretty much physically impossible that all patients, even with full gold card access to care, could possibly be getting good care. Elliot and his colleagues pointed out that where you lived and which physician you saw was more important than whether you had insurance in determining the care that you would actually receive. Insurance was somewhere down the list. There were far more important issues that we needed to understand and deal with along the way. Now, generalize the list. In the run-up to the ACI, I was asked to testify 4 times to various committees in Congress. Of course, this was Senate Finance, the main committee of record for healthcare policy in this town and in our country. I took that variation literature and broke it into 5 major subcategories and presented it to them just One way of understanding a truly massive literature at the time, if you did a Medline search looking for articles in the peer-reviewed medical literature documenting variation in practice, you could roll out more than 40,000 articles. Amazingly extensive and amazingly consistent in findings. The top of the list is the variation we've been talking about, really championed by the Dartmouth Atlas, but then validated by many, many different groups in many different places. Now, number 2 on the list, some suggested that perhaps we could explain geographic variation by something called inappropriate care. Inappropriate care was totally a clinical model. Care was judged inappropriate if the risk inherent in a treatment outweighed any potential clinical benefit to the patient. This among professions that hold as our primary maxim, first do no harm. These would be areas where we put a patient actively in harm's way. The risk outweighed any potential benefit, should never have been undertaken, but we did it anyway. 2 major findings from that body of research. The first is that inappropriate care does not explain geographic variation. Low utilization communities around a particular clinical area had about the same amount of care judged clinically inappropriate on average by one's professional peers as did a high utilization area. The secondary finding, though completely unexpected. Well, in the initial series of studies, the high water mark was 32%. Of all carotid endarterectomies performed in this country, random sample, valid estimate, 32%, about a third, clinically inappropriate, should never have been done. Since we've had other trials, the COURAGE trial in cardiovascular medicine that suggests half of all cardiac cath with stent placement, clinically inappropriate. Risk outweighs any potential benefit, should never have been done. Stunning, stunning challenge to the values and precepts of the healing professions. Deeply troubling. Number 3, November 30th, 1999 is when that same IOM committee published to Erich Human. We initially estimated 44,000, 98,000 preventable deaths each year in hospitals where the cause of death was not the patient's underlying disease, but preventable complications of their care. The care was the cause of death. Lots of sub-arguments behind this. Let me just say that when we made that estimate, we'd done a careful evidence review, found about 60 major studies. We were trying to be conservative, and we were. Participated in subsequent research that said the real mortality rate is about 210,000 preventable deaths per year, with better, more sensitive tools for detecting patient injuries inpatient. Same across the world, by the way. We're no different from other countries in this regard. Now, remember, on average, care adds 3.5 to 7 years of life expectancy, on average, for every American citizen. The upside is dramatically higher than the downside. You'd be an idiot to refuse to get care because of your fear of the complications that arise. Hugely bigger benefit. Most people, I don't think, ever read the second half of that report, though. The main point was, yeah, I understand that any care powerful enough to heal can also harm, that you're walking a thin line between help and harm very often. I've practiced medicine. I get it. The second half of the report pointed out that we had proven methods by which you could dramatically drop the injury rate without losing any of the benefit. That was the point. I don't know how to make it perfect, but I know how to make it way better. That was the point, you see. Number 4 on the list, it's really the swing side of patient injuries. It turns out that we have some areas of care where we know that they work. It's a relatively short list comparatively, but a series of treatments that are well established in randomized controlled trials, general consensus across the profession that they're beneficial. People started to go in and measure how well we execute it. It's called reliability. For things we know work, how well do we execute? Beth McGlynn at RAND, probably being the best researcher in this area. What Beth showed is that for adults, we managed to get it right 54.9% of the time. For children, 46% of the time. Now, it's pretty easy to make the case that we fairly routinely achieve miracles for the people who seek our help. In terms of the health outcomes we achieve, pretty easy case to make, actually. That 3.5 to 7 years of life expectancy, net of everything else. If we can achieve miracles doing it correctly half the time, what kind of miracles could we achieve if we did it correctly all the time, or something close to all the time? It means we're leaving an awful lot of human pain, suffering, and life on the table. We could be dramatically better. The right way to think about this, it's really a list of potential. It's the duty of every generation of the healing professions to pass along something better than we ourselves received. That's the story of medicine, seriously. that constant growth. And the first step in that growth is to carefully examine your own practices, critically examine them, and find areas where you could be better. Now, that's the right way to think about this list. It's easy to make the case on the evidence that care delivery today is the best the world has ever seen, far better than any previous generation has received. At the same time, when we carefully examine our practices, we discover that we could be far better still. So therein lies the challenge. This is really a list of opportunities rather than a bill of indictment. It's not that healthcare is broken. For something to be broken, it had to be working. It's working, then it breaks, then it's broken. There is no good example of it working on a broad scale. So think of it as a huge opportunity for being dramatically better. Huge potential for better. Oh, if you take the top four and roll them together, what you get is waste in the system. These are actually, in quality theory, areas of waste in a system. In fact, in 2010, another IOM committee, we pulled together the experts, reviewed the evidence. We concluded that a minimum of 35% and probably over 50% of all resources spent on care delivery today in the United States is technically waste, non-value adding from a patient's perspective. I could break it out for you in specific examples and subcategories. I'll at least list the major subcategories moving ahead. Now, you need to know I'm a bit of an outlier on this. Didn't carry the day. My models come up with closer to 70% waste. 50%, 70%. I mean, the level of waste is not critical when it gets that large. It's not worth arguing about. A massive opportunity for cheaper, more affordable, more accessible care through better care. The key thing that Ed Deming showed in quality theory. See that idea? Yeah, it's huge. The point is the opportunity is stunningly huge. Can you think of another area of the American enterprise that has a market capitalization rate of $1.7 trillion? This year, the United States will spend about $3.4 trillion on care delivery, and I'm suggesting that half of that is recoverable waste, potentially. Nothing even comes close in terms of financial opportunity. There's another fun thing, looking at it from a care delivery system perspective. There's a way of breaking it out that really makes sense. It started with activity-based costing systems. What you're really looking down at the bottom is something called efficiency. So what you do with activity-based costing is you break all care into little teeny things called units of care. Single dose of a drug of a particular type by route of delivery, any single lab test, any single imaging exam, acuity-adjusted hour of nursing services, an acuity-adjusted minute in a procedure room, a 6-minute block of physician's time, anything from central supply by specific element. A cost master for activity-based costing will contain a minimum of about 25,000 items for a typical hospital. But you break it out into these little granular elements. Well, waste level 1, what's your cost of production for an element of care? How much does it cost you to acquire and deliver that dose of ceftriaxone, a particular antibiotic? See that idea? Maybe I could get a better contract, which would reduce my cost of acquisition. Well, I'd count that as waste, believe it or not, in this system. Maybe I get a more efficient CAT scanner that reduces my true internal cost for performing the exam from $300 down to $200. So I reduce the cost of unit of care. Just in passing, Uwe Reinhardt at Dartmouth points out that you can completely explain the difference in healthcare costs between Europe and the United States through unit costing at this level. Our costs for physician time, for example, for nursing time, for medications in the United States are dramatically higher. I diverge from Uwe, though, in this level because I look at that list of 5 elements. I think that that's just the tip of the iceberg. The opportunity is dramatically larger than that. Now, when I actually treat a case in a hospital, I bump up to level 2. It's called within-case utilization. That's what I quickly rush by with our little QUE studies. Variation in how many units of care of what type you use to actually do a particular case. So one of the major sub-elements of within-case utilization is clinical variation in care delivery. Patient safety fits there too. It's net waste impact as you always, if you have a patient safety event, increase your resources that you consume. You see, administrative inefficiencies fall into this category. It's actually fairly large. But as soon as I get to the case level, there's a level above that. It's population health up at the top. It's case rate utilization, the number of cases treated at a population level. So some of the key work that Dartmouth Atlas did was talking about preference and supply-induced care, preference-induced demand. Estimates of 20, sometimes 30% of all care delivered that, frankly, if you did it correctly, would not be necessary at all. You don't do the case to begin with. So you see the three levels. Cost of a unit, how many and what type of units to do a case, when do you choose to do a case. Now, I build models of these things for fun. And when I build my waste models, I can estimate how much of the opportunity falls in each category. This is from mine. We could challenge it and debate it at some length. It'd be a fine academic debate. I predict that it'd come somewhere along these lines. Traditional administrative efficiency down at the bottom, about 5% of the total waste opportunity. The biggest is actually within case utilization, variation in care delivery. It's about 50%. Population health, though, a similar massive opportunity, about 45%, at least when I model it. I'm sure that they're not precise, but they'll be close enough for policy debates, is the basic idea behind this thing. Yeah. Now, the next thing we need to know around this, when you invest in waste elimination, so think of it as investment. It does take resources. Quality isn't free. It just has a heck of a return on investment. You think of how much do I have to invest and what do I get back? Working in a care delivery system down at the front line, it's always measured in terms of operating margins, where you live or die. You have to be able to pay the staff. You have to be able to keep the power turned on. You have to be able to buy supplies. That all centers around operating margins. Traditionally, the way that people have maintained those operating margins is by doing more, by increasing revenues. Build that new heart hospital, recruit that famous surgeon to do more cases. Somehow think about how you could do more imaging or more lab work, right? Bring up those revenues. Now, when you do that well, for the money that you invest, revenues you generate, about 5 to 9% actually find its way to your operating margins, if you do it well. The fascinating thing is when you go to the waste side for the same investment, you get 50 to 100%. It depends upon specific underlying waste mechanisms, but you'll get a minimum of your variable cost rate. We call this financial leverage. So for your investment, how much leverage do you get back? What I'm doing between this idea of how much waste is there, at 50%, let's say on average, and then this idea of leverage is trying to make a compelling argument why any competent care delivery leadership team should focus on waste. At the present moment, the waste opportunities in the system are dramatically higher than the traditional academically based revenue enhancement strategies. They're at least an order of magnitude higher, probably 2 orders of magnitude. If you're only interested in the money, you should be focusing on waste. That's the point behind this whole argument, you see. Now, yeah, next thing you need to know, we have proven methods by which we can address the underlying elements that lead to variation in care, that lead to patient injury and harm. They've been well established over the last 20 or 30 years. There are several different forms. My favorite, I participated in it heavily, is called shared baseline protocols. I don't plan to go into the details. What you need to know is we have proven tools for dealing with this stuff on a fairly broad scale. So we have the target and we have the methods. It's not a matter of knowing, it's a matter of doing within the system for the moment. Can I just show you one example of one? It's actually a Generation 3 patient-centered medical home. So Gen 1 for us was chronic disease management. To deploy it, we had to build really good decision support, clinical decision support. Then we had to deploy it into clinical practice. It required that we hire something called care management nurses. We identified major chronic diseases, type 2 diabetes mellitus, heart failure is a big one, all right, asthma, hypertension, big chronic conditions. Built shared baseline protocols, evidence-based best care, around which clinicians could vary based on patient need. That's that clinical decision support system, backed it up with good data. One care management nurse could support about 4 or 5 primary care physicians. The problem was the insurers wouldn't pay us for them. So internally, we did a series of trials to demonstrate that if you deployed this Your physician productivity went up sufficiently by itself to pay for the nurses, but you got dramatic reductions in hospitalization rates and the like. Major cost savings if you looked at a systems level. So as a system, we deployed them anyway. Those care management nurses everywhere we could put them, showing that they were effective because better care, moving upstream, driving lower cost, more than justified the investment. It took a sophisticated financial follow-through on good clinical care, is what it took. Level 2, patient-centered medical home. Dr. Brenda Reese-Brennan got us to focus on mental health integration, particularly depression as a chronic disease in an outpatient setting. Another series of trials. It turns out that if we better identified patients with depression, invested more heavily in managing their primary condition, their mental illness, it expanded beyond depression, that, well, what we call somatic illness, secondary treatment for other medical issues dropped rather dramatically. We demonstrated that that saved money too. Oh, this required that we put psychologists into those same primary care practices. Insurance companies wouldn't pay us for the psychologists. We had no way to bill for them under the current system. But it still saved enough that it made sense if you had the sophisticated financial follow-through, was the big if along the way. Level 3, we published this last summer in JAMA. We added care coordinators. Well, their real purpose was to coordinate community resources around a patient's need, not just the care delivery system, but other local government, state government, churches, schools, other resources in the community. We use social workers. Others have shown that you don't have to spend that high. You can use other people in different roles. Same thing. Well, then we ran a trial. It's about 200,000 patients. This is what we published. Clinical outcomes got better. By this point, you expect that. But I wanted to show you the financial impacts. This is from the paper. What you can see what's happening here. Hospital admits fell by 22%. That's the biggest financial contributor right there. Through better care. Move upstream, eliminate the need. So they don't need hospitalization. Other admits, 21% fall. Emergency room visits, 11% fall. Not too surprisingly, primary care visits went up 4%. That's exactly what you'd hope to see. Yeah, urgent cares are walk-in primary care clinics 24/7. You'd hope they'd go up too. You'd much rather that a patient goes into that urgent care than into the emergency department. I believe on this slide I show radiology test lab fell similarly. When you total it all up across that large population, our investment to put team-based care into place was $22 per person per year. Medical expense dropped by $115. Now, folks, that's a pretty good return on investment. A little bit more than a 5-to-1 return on investment. That's productivity of the healthcare system that you're seeing coming up. That's serious money along the way. Just to make a case, though, it turns out the reason I laid out the waste mechanisms the way I did, they directly interact with payment mechanisms. This we published last summer in Harvard Business Review of all crazy places. But the whole point is that waste elimination strategies always require investment. When they work, they take out waste, but who gets the benefit? Turns out it depends on payment mechanisms. I have to make the investment. A red triangle means that I don't get any of the money that results to offset my investment. I only need an offset. But if I don't at least get the expense of the change, my ability to do more of the same moving forward is greatly attenuated. A little red triangle pointing down means that all of the savings go back to purchasers, and I have to eat the cost of the change. A green one means that the financial incentives actually align. So this is really that part about aligning financial incentives. Can you see why any good health system today should want to be in that right-hand all green column? If I'm paid, for example, bundled payment per case, it means I'm leaving 45% of the waste opportunity on the table. The financial incentives don't align. If I'm paid fee for service, holy cow, I only get 5%. I'm giving you the underlying argument for pay for value. Frankly, seeing CMS, Department of Health and Human Services, try to shift the country as a whole into pay for value makes perfect financial sense in this kind of an environment. Oh, I'm laying out the whole argument behind ACOs. Can you see why a good care delivery organization, from a purely financial perspective, forget the ethics for a second, can you see why you would want to move into provider at risk care if you could manage it? It does just happen that that's where your ethics align. The way that you get that is through better care, where the care of the patient comes first. And it relies upon managing processes of care, that core idea of patient-centered care that we first talked about in Crossing the Quality Chasm, is where it all ties together. Just to show you it's real, now I left Intermountain on October 21st, so I don't know if I'll get another update on this. At Intermountain, we decided to pursue this strategy. Long story short, we decided that to keep our costs affordable in the community, by the end of last year, we needed to take out 13% of our costs of operations. I have complete data. Now, this is not from me. This is from our finance guys, which means they actually believe it. We had already hit, if I can get the slide to advance, the 13% level. We'd taken out just under $700 million of our costs of operation through waste elimination. Now, Jim, that's productivity. On the hoof, my purpose in showing you this, it's real. This is not theoretic, this is not speculative, this is not merely academic. This is just as real as it could possibly be. In fact, I'll tell you, we took a bath on the risk corridors on the ACA. Currently, the federal government owes Intermountain about $450 million, which for us is a lot of money. If not for this right here, we would have been seriously underwater. This allowed us to subsidize the federal government's program at this level. This is how it happened for us, at least. Yeah, well, I think you get the idea. Now, I want you to come back again. The driver, I showed you this earlier, it's the idea of these processes of care, the light blue lines, extending down through what we call continuum of care. In quality theory, I'd call them processes, extending down through those health categories that we talked about earlier. I want you to think about this idea of move upstream strategies. As soon as I talk about waste elimination, I'm talking about move upstream. You see? I threw in some examples of it here. Well, we've talked about medical homes right here. A medical home up at the top, right at that level. My third generation patient-centered medical home. I'm pulling those patients out of the hospital and the ED up to a primary care level. Other examples in the country where we pull them out of the hospitals and clinics up to an environment level, getting the homeless folks in your community to have housing and reducing their ED visit rates. A proven strategy, initially started in Denver, Jeff, interestingly enough, for the country. And we've taken real advantage of that in Utah now. Do you see this idea? In my full list, I have about 60 move upstream strategies as general strategies. Atul Gawande called them hotspotting, is another word for the same thing. So a theoretic framework within which it takes place. So in this context, a funny concept, I have a friend who's a senior chief medical officer for a major for-profit insurance company, one of the big ones. He made the most outlandish claim to me a couple of months ago. He claimed that he was the largest employer of primary care physicians in the United States, over 25,000 primary care physicians. I had a lot of cash sitting around, and these folks have been buying up clinical practices. But they're buying primary care. They aren't buying hospitals. Why would they buy primary care? Why would they stake that kind of a bet on that particular future? Well, it's right here. He believes that they'll be able to move upstream, take waste out of the system, create value by taking out waste. He's really going to take it out of the hides of the specialists in the hospitals. Just as I showed you earlier, that's his exact strategy. If he can pull it off. That's still an open question, by the way, is can he manage a primary care practice at that level? We'll see. My prediction is probably he can. Elliot, I think that our definition of an ACO may modify and change. Functionally, it'll have the core of it, but if these people are successful, we'll get that function perhaps under a different name. Well, it would be fundamentally transforming if it happens. what does this really represent? You know, truth is I've known Clay Christians for most of my life. We first met when we were in our 20s. Clay likes to talk about disruption. I think this may be a major disruption coming for healthcare in ways that Clay never really anticipated in the past, particularly. Most care delivery systems thought about maintaining their financial stability through revenue enhancement. Add those new services, a traditional academic model, frankly. Quality was defined as regulatory compliance. Look good enough on the federal profiles. Avoid the federal financial penalties around Medicare, for example. Well, under these strategies, there's a fundamental shift. Quality becomes your core business strategy. You have to manage those processes of care to move upstream, deliver better care, and take out waste. You see? So quality becomes actually your core business approach. And bottom line cost control, at least for the next 15 or 20 years, becomes your primary financial strategy. Waste elimination, as opposed to revenue enhancement, dramatically higher financial leverage. And I think underneath it all, that's what we're going to see happen in health reform moving ahead. This is the heart of health reform, at least to my mind. Implications. We'll see an increasing focus on waste elimination through move upstream strategies. We'll see care delivery organizations increasingly seeking capitated risk. It's taking the form of consolidation. I'm not so interested in consolidation of care delivery groups. What I find much more interesting is big integrated care delivery systems building their own insurance arm, or insurance companies buying the care delivery system. And I predict we're going to see this confluence of the financing arm integrating with the care delivery arm. When you start to really work it through, it's the only thing that makes strategic sense. And I think we'll see a real increase in that moving ahead. Fundamentally, the current insurance model is not viable. I think it's going to be changed. Well, that's why all of the big insurers are buying care delivery. I've met and talked with them. They see the same thing in their future. What it does, by the way, is reduce standalone specialty care practice in hospitals, traditional academic medical model, for example. In this kind of a model, they become what are called price takers. They compete solely on the basis of cost. A uniform high standard for level of performance, but purely cost-driven, with no real future in that sense. I think it's going to be completely transformational. That may be an overstatement, by the way. Smart people there, I bet that they can adjust their strategies too. What I see, though, as a new world, we have not yet begun to understand how good we can be for patients in terms of the outcomes we achieve. And as we do it well, care will become more and more affordable. Healthcare delivery today could solve the federal government's deficit problem, at least for the short term, if we could pull this off. And it's the right thing to do. It's the best way that you could possibly meet our primary mission to serve our patients. Cheaper care through better care. So I actually see a fairly glorious future for medicine moving ahead. I think our level of understanding has improved, and with that, better models, better performance, well, better care. With that, I'm done. So back to you, Jim.
Okay, well, Brent, we have you surrounded now. I'm Joe Antos with the American Enterprise Institute. Let me introduce the rest of the panel, and I will introduce the panel members you haven't met yet in the order that they'll speak. So first, Elliot Fisher, who is the director of the Dartmouth Institute for Health Policy and Clinical Practice. And he's the John Wenberg Distinguished Professor of Health Policy and so forth at Dartmouth as well.
so forth. That's like,
Too many syllables. Right, this is called efficiency. And then next is Farzad Mustashari, who is co-founder and CEO of Aladad. But before that, he was the national coordinator for health IT at HHS, and has been around a lot of places related to primary care and healthcare. And then finally, Jeff Selberg, who is I think this is correct, Jeff, the founding executive director of the Peterson Center.
That's right.
That's correct, yeah. Center on Healthcare. That's the Peterson Foundation in New York. And prior to that, he was CEO at the Institute for Healthcare Improvement. So with that, I'll make a few comments. I thought, Brent's discussion was inspirational for an economist because after all, this one chart that showed where you can really find the money, that's what economists are very interested in. But Brent also made a passing reference to the Medicare program. And so you have to wonder, where does Medicare fit in all this, since it is the biggest payer in the country? And to a large extent, its grip on what I consider to be at least the payment system of the past says something about where the future lies or how hard it will be to get to that future. So with that little editorial comment, why don't we move to Elliot and see what he has to say.
Well, Joe, Jim, thank you so much for having me here, and what a treat to follow Brent. I mean, his work has changed the way we all think about healthcare in terms of how feasible it will be to do all this. I want to start, though, to emphasize one of his points about case rates. So every healthcare system in the world is based on a lie. Actually, 3 lies, but I'll only emphasize one. Here it is. Doctors can tell patients what's good for them. I'll do a little bit of a story. My father, when he was 70 years old, dissected his aorta, which is this big vessel in your chest. He had his life saved by the miraculous things that medicine can do. They cut off the top of his heart, replaced his aorta. He survived and went on to have another 20 years of wonderful, productive work. It would have been obscene to do the same procedure to him when he was 90 and suffering from severe dementia. Physicians can only tell you what's good for patients when they understand their goals. And one of the fundamental challenges we have to think about in the healthcare system is how we're going to get healthcare aligned with meeting patients' goals and interests. And that's actually a fundamental to markets and how you make them work. So what I want to do is I did help with Mark McClellan launch this idea of accountable care organizations. And I want to remind ourselves a little bit of how we got there, which was really pretty well highlighted by Brent. Huge uneven quality, failure to align treatment with patients' goals, something we care about deeply at Dartmouth, deeply fragmented care, and pervasive waste. So as we started to think about the problem, the question was, how can we get the policy system, the policy world, to address the underlying causes of poor performance in U.S. healthcare? And one was lack of clarity on aims. We weren't really thinking about what the aim of healthcare was, and Brent laid it out beautifully: better care at lower costs. There was lack of accountability. In fact, we had an incredibly fragmented accountability. Doctors were under one quality system, hospitals were under another, nursing homes, home healthcare. All this fee-for-service reinforced both the fragmentation and this fragmented accountability. And then deeply flawed incentives, where you're rewarded for doing more stuff, not better stuff. We also recognized, and this was really in a wonderful set of encounters with people from around the country as they thought about what it would take to change healthcare, was recognizing the diversity of the U.S. healthcare system. So, unlike many other payment reforms, which were focused on deeply specifying exactly what the requirements were to be a patient-centered medical home, for example, we said, let's set the goals: better care, lower costs, and let's let the market determine the structure, the forms, surface the forms that could do better, that could deliver on this. We were lucky enough with hard work and help from colleagues to get it into the Affordable Care Act. There are now about 1,000 ACOs covering over 30 million people, 30 million covered lives. But where are we now? You go, damn, we haven't changed the world yet, right? What a bummer. A couple of colleagues and I just published an article in the New England Journal last week which really looks at why are ACOs being slow to achieve savings. It's important to note they've improved quality pretty consistently, and it's important to note that many of them are doing pretty well, and I'm sure Farzad will tell you more. So I want to focus a little bit on why ACOs are, why we're not there yet with accountable care organizations, and then I do want to talk about this challenge of why spending continues to increase and the behavior we're seeing on the part of institutions protecting themselves. So let's unpack those two things. Why are ACOs slow to achieve savings? We link data on the type of ACOs. We've done a national survey of accountable care organizations around the country, and we link data on the type of ACO one was and performance, getting data from Medicare. And three types of ACOs. Physician groups that don't have hospitals. That's an important point to make. Hospital coalitions, the newly formed organizations that have some physician groups, and then third, integrated delivery systems. And what we looked at was how quickly did they achieve savings, or did they achieve savings at all? And we measured savings in terms of the percentage of groups getting a bonus. So at the end of year one, 30% of each type of those ACOs had achieved savings. At the end of year two, the independent small medical groups had started to achieve substantial increases in the proportion receiving bonuses. And by the end of year three, 51% of them were receiving bonuses from Medicare for having improved quality, because you can't get a bonus unless you're improving quality as well, and achieving savings. The hospital coalitions, newly formed organizations, some of them with medical groups, some small, some of them with own practices, but new organizations. It took them a year to get going. They really didn't do much in terms of the year one to year two transition. But by year three, about 47% of those, I guess that's not about, is it? 47% of them were achieving savings. Interestingly, integrated delivery systems stuck at 30% in terms of getting bonuses across the whole 3 years. So what we talked about in the article, and it will be posted on the website, I understand, so that you can easily find a link and read the nuance, because there's a fair bit there. But we distinguished barriers to improve performance that are related to financial incentives and those that are related to organizational barriers to change. On financial, we highlighted the question about depth of the incentives. That is, are you bearing risk? Is it really scary? How strong are the incentives? And then breadth of the incentives. You know, are you under an ACO or total cost of care payment model for just a tiny fraction of your patients, which turns out still to be true for almost all healthcare delivery systems. Only a small fraction of their patients are under this total cost of care virtual capitation model. 60 to 70% of the money is still coming from fee-for-service. It's impossible to change your behavior until you have at least, their evidence seems to suggest, 60 to 70% of your payment under this new payment model. So the classic cliche now is 1 foot on the dock, 1 foot in the canoe. But we also highlighted organizational issues. You know, what's your depth of experience? Do you have knowledge required to implement the kinds of new models we'll hear about from Jeff Selberg? And size and complexity. You know, how big and bureaucratic are you? Little foreshadowing of why maybe integrated delivery systems didn't improve at all. So I think where that led us to make some recommendations on policy to try to get us to a place where we can really do better is first, we need to move as fast as we can toward a common set of incentives. We need to figure out how to get Medicare and commercial plans toward virtual or virtual capitation or actual capitation, and I still don't think we know whether it's really critical that it be all risk-bearing. I think the evidence is more controversial, as we argue in the New England Journal piece. It may well be that the possibility of having all of your payments under even virtual capitation creates enough of incentive, as Brent was showing with his 4 green triangles pointed upward or downward? Upward. With, you know, that there's enough money to make even under virtual capitation, that you will have the incentives to do it. So I think we should be agnostic on that and move as quickly as possible. The second, and it's interesting, imposing risk too quickly on Medicare shared savings programs or the smaller ACOs, which may get nervous about bearing risk, could be really harmful. We might have 500 of those ACOs that are out there having chosen not to go in to this payment model. So you may want to think about the speed of transition. The second thing is, if you're a big integrated delivery system, it may be really important to put you under risk because you're not changing your behavior. Harumph. So that's sort of the ACO picture, quickly framed. I think we have a tremendous opportunity, as Brent outlined, to do better. Let's spend a second on why costs continue to rise. And I think it's about the behavior of institutions that are trying to preserve their current models. I teach in a business school with partnership with Tuck, a mid-career program that teaches leaders who are already in the C-suite and preparing to become CEOs or headed that way. And from my students, who are all working in hospitals and these kinds of organizations, they say, Elliot, it's a no-brainer. We're in this to make money. It's an open secret in the C-suite. And maybe to everyone here, that the way hospitals behave is completely related to the financial incentives they're operating under and the hard work it is to eliminate waste. It's so much easier to do other things because you've been taught in your MHA program, your Master of Hospital Administration, how to generate revenue. Hospitals actually see the ACO model as great for them. They focus on their sickest, highest cost patients, Medicaid patients. And you don't get paid much for taking care of a Medicaid patient, by the way. Even Medicare patients don't pay you as well as commercial patients. So the benefit to being in the ACO model for an ACO is to reduce hospital utilization by 30% for your low profit patients and free up those beds and use them for higher throughput, high profit patients in the revenue model that you're used to. So and I think it allows medical centers to shift toward quaternary care. And none of that is saying anything about using your monopoly power to raise prices, which, of course, they're all doing if they can, because it's easier to raise prices than to do the hard work Brent was telling us we all have to do. So what might we do? I would encourage us to move as quickly as possible to capitation or virtual capitation for everyone. And the key question for people in this room and elsewhere is, what incentives might we have to get all health plans to align around a common set of measures? You don't even have to change, the rewards could be different because those should be contractually figured out, but a common set of incentives so everyone, every healthcare organization in the country, primary care practice or otherwise, faces this same set of positive incentives that Brent laid out for us. And then I think the other thing is we really have to talk about transparency. What Jack taught us 40 years ago was there's magic in making the invisible visible, in revealing the magnitude of variation. And I think the opportunity to look at the market level at least and show where are the places in the country where providers are brilliantly lowering costs. Right now we don't know that because the commercial data is invisible. The best we have is Zach Cooper's work, which suggests that Rochester, New York is able to be one of the lowest cost places in the country for Medicare and one of the lowest cost places in the country for its commercial population, but there aren't very many other great examples. There's a market in Iowa, Dubuque. So we want to create transparency to show us the bright spots. And then we want to shame the others because they're stealing the money from our kids, from our infrastructure. I don't know how many of you ride a bicycle, but I do, and I hit a lot of potholes. And that's because healthcare is taking the money from our communities. So that's a little bit of a provocative, fun way, I hope, of starting the discussion. We have tremendous opportunity to improve. I'm with Brent. It's half of spending that we could take out of this system and give it back to our kids. Thanks.
I'm a little worried about putting public works in under Medicare, but I suppose that will work. The prices will go up, immediately. Yeah, exactly right. But we'll still be waiting to get those potholes fixed. So really, won't have much difference. Okay. Well, I misunderstood. Farzad, you're next.
Thanks so much for having me. I'm a late convert to the idea of financial incentives being the most important thing. But I'm all in on this. I spent 15, 20 years as a public health professional, working with small practices, primary care, working with technology, all to say we can do a better job of doing what we know works, right? And thinking about supports, thinking about information, thinking about transparency, thinking about technology, feedback. And I kept, banging my head against the wall that I didn't want to see. And what I didn't want to see were, it's all about the incentives, stupid. To paraphrase, someone who I really loved, Uwe, and, really thinking a lot about these days. So what are the incentives? And I think Brent laid it out very well. The one piece that I want to take the conversation forward from where Elliot and Brent left it is around the issue of consolidation. And the key thing here is that if you are big enough, if you're the must-have health system that has bought up all the practices, that owns and controls that market, then the health plan becomes the price taker. And if you're a must-have in the network, and you want to continue saying in the fee-for-service system, and you're very comfortable in that, and you don't have to be a for-profit, right? You could be a nonprofit that has no incentive to become more efficient because you don't want those nonprofits to go up too high. You just want to be comfortable. Then there's no incentive for you to. There's no really way right now for the market itself to fix the problem. So that I see in about a third of our communities now, those markets are considered highly consolidated. And those trends are continuing. And in some cases, the ACO movement, and there's some conspiracy theorists out there, I really do not think that there was any intentionality to this, but the net effect has been that if you can set up an ACO, not for the purpose of really generating savings at all, but for the purpose of getting the claims data and seeing where people are referring patients, locking down on those referral networks, you actually can end up increasing kind of the Pac-Man consolidation, the vertical consolidation, hospital to physician, specialists, and so forth, where you tip the ball to yourself. Not for the good purposes of taking on capitated risk, but for the bad purposes of locking in those high fee-for-service rates. That is the threat that Paul Ginsberg, Marty Gaynor, and I, working with actually Scott Gottlieb, and we had some participation from AEI and others, we did a series of policy recommendations around how to improve competition in healthcare, how to make healthcare markets work. And that to me is the number one thing that we should be concerned about in this movement towards a better future. So, what are some of the ideas about what we should be thinking about? And let me say, what I'm doing on the private side, having started this company now, we're now in 20 states, and we're offering physicians, those independent physicians, who really can be successful in this, instead of joining the hospital or letting yourself be bought by a big insurer, we're saying to them, we will give you the support you need to stay independent. We'll give you the technology, we'll give you the capital, we'll give you the organization, we'll get you those contracts, and we will share if we together reduce those case rate utilization within case utilization and shift referrals to have better unit cost. If we can take that 50% waste out of the system, then we can all be very happy, and we can use that as an engine for growth without joining the hospital. So ACOs, if they're physician-led, can actually be an anti-consolidation force. And I think this is something that is missed in the debate about ACOs. There's a lot of folks who are concerned about consolidation and competition who see ACOs only as being hospital-centric, whereas in fact, as Elliot said, the most successful ACOs are keeping those independent physicians independent and prospering in this new way. So a few quick summary of the much larger piece that we published on competition. The first is stop digging the hole deeper. There are payment policies that we're doing that are encouraging consolidation, we're digging the hole. So let's stop digging that hole. So why should we pay for the same service delivered in the same place by the same person twice or 3 times as much from Medicare if that practice gets bought by a hospital? Site-neutral payments would do a huge favor for us to put on a level playing field larger systems and smaller and independent practices. We also do have to address anti-competitive behaviors on the part of those large and consolidating health systems. One large health system said to our docs, "We will not give you data when your patient leaves the hospital. If you want that, come join our network." We view that information that data as a strategic asset. So, data blocking is not a myth. Data blocking is really happening and is being used as a weapon for consolidation. So those are anti-tiering, anti-steering provisions in contracts. So it's not just around enforcement, it's also around making sure that there's free flow of information to the people who really need to have that. The second big recommendation, I think, is around new entry for one of the really most successful ways of capitating risk that we've had, which has been the Medicare Advantage program. And the MA program has huge potential. It makes so much sense once you can do that. But there's been relatively stagnant MA market in terms of new entrants because of how hard it is to meet all of the regulatory requirements and network requirements. In many parts of the country, there's actually a lot less competition in MA than there is on the exchanges. And we all talk about lack of competition on the exchanges, but there's actually a lot less competition in Medicare Advantage. So there's things that the government could do to really promote entry into Medicare Advantage by, for example, health systems that could take capitated risk, by simplifying the requirements, net requirements, and also letting the government continue to do the claims processing, which is the least important part of running an MA plan. And then third and final, I really believe that the ACO program has done a huge amount of good in moving the system and in getting a huge amount of private investment in that direction. But I think we need to continue to be better. We need to continue to iterate it, not throw out the baby with the bathwater, but we do need to continue to make it more reflective of the value that's actually being created. So we run we're in 20 states, we run 20 ACOs on the Medicare side, beginning Jan 1, and about a dozen others on the commercial side. And I can tell you, those of our ACOs that have, quote, made money, that have actually, gotten savings compared to the benchmark, are not necessarily the ones who have done the best work. It depends a lot. If you're in Kansas and you had a 10% regional increase in your costs, and our costs only went up 2%, under the data that Medicare puts out, and Elliot quoted, we would be classified as having increased costs in Kansas. Well, that's just not true, right? So that lack of predictability between the actions that you do and the outcomes you get and the financial rewards that you get or don't get is a big problem in the system right now. And by improving the counterfactual, as it were, making sure that it's like Medicare Advantage, risk adjusted, like Medicare Advantage, regionally based, those would do a huge favor in terms of continuing to support appropriate investment in that model. Thank you.
Thank you, Farzad. You mentioned another one of my favorite topics, which is the baseline. If you set the baseline right, you've made money, or at least you've taken money out of the Treasury, which is actually better than making money. This raises lots of questions about whether the federal government is very good at creating business enterprises, because that's what ACOs. That was the ACO initiative, to create business enterprises. I have to say that the history of the federal government, at least our federal government, creating successful business enterprises has been pretty limited.
Medicare Advantage.
it didn't create those plans. It created a structure around which those plans.
What's the difference?
What's the difference? Oh, there's a vast difference. ACOs only existed in the minds of the Obama administration, but we can get into that in a minute. They now exist. I admit that they exist now, but they didn't exist prior to that. At least not in the construct of the Medicare program. And as everyone on this panel knows, the baseline issues really determine everything about success or lack of success. And I think arguably the baselines were set in an abysmal way, and I think the changes probably are going to find their own problems, not necessarily their own solutions. Anyway, with that very optimistic note, Jeff.
Thank you, Joe. When you go last, you have the problem of wanting to respond to the panel versus doing your own presentation. I'm going to try to do both, and probably I'll have a coherence challenge here, but here we go. The thing I worry about in terms of the ACO effort is that I think we're just teetering on flipping back to a fee-for-service model because the operators in healthcare are going to say it didn't work, and moving forward just along the lines of what Brent and Farside and Elliot said. I also wonder about the public's willingness to move into a lock-in benefit, which I believe full capitation requires. We attempted some of that in the 90s with a very, very big backlash, mainly because the quality of the service that was provided was abysmal to individuals. So I think we're right on the precipice, and I think that the question is the people who are responsible for the care, are they actually going to move to improve it, or are they going to move to control it? And I was in hospitals for over 4 decades, 25 years of which were as the chief executive, and I can tell you, until Errors Human came out, my main interest was a balance sheet and a profit and loss statement, and my main interest was how to game the system to do the least to get the most. And unfortunately, there's a whole lot of people out there. I'm a converted, a zealot, evangelic in all of this, I will admit that. There's a whole lot of people out there, whether they're on boards or they're in executive suites, that see their balance sheet, their profit and loss statement as critical. Nothing wrong with that, but the key is to protect it by improving the care, improving the service, as opposed to gaming whatever the incentives are. And I can guarantee you, incentives can be gamed no matter what they are. A little bit about my bio. I started in hospitals in 1967. I had my first chief executive officer appointment in 87. But it wasn't really until the 2000s when To Errors Human came out, which Brent referenced, that I had my comeuppance. And my comeuppance was that my first reaction, in all honesty, to Errors Human was that it wasn't my issue. Even though I had responsibility of thousands of employees, 50,000 admissions a year, it wasn't my issue, because my belief was physicians write the prescriptions, and that's where the issue was. Unfortunately, we killed a patient who came in with pancreatitis, and we overdosed that patient through a comedy, unfortunately, a tragedy of errors. And I realized it was very much every one of our issue. Quality is everyone's issue. So I got interested in To Errors Human by virtue of that personal experience, and crossing the quality chasm was the breakthrough, I think, that Brent has described. I left the field in 2010 to become the chief operating officer at the Institute for Healthcare Improvement, because I was very interested in improvement at that time based on my personal experience, and then I joined Pete and Michael Peterson in 2014. My interest in helping them to create the Peterson Center on Healthcare was that my experience in the field and at IHI is that there are bright spots. Were bright spots then, and there are bright spots now. And all we needed to do was to find them, validate them, and spread them. There are models of care, primary care, virtually in every specialty, that are outstanding. They're low cost, high clinical outcome quality, great patient experience, and high physician engagement. So Pete and Michael Peterson said, let's go out and find those because we need to spread them because as the panel members have said, there's a tremendous amount of waste. You can quantify it into almost maybe over now $800 billion. If you were able to get that out, it's the equivalent of what we spend in K through 12 education in this country. It's a huge number. But how do you get it? And our interest was to find the bright spots, validate those models, understand the features of those models, and then initiate a spread effort. And that spread effort we wanted to set at a 5-year goal across the country as opposed to a 17-year average is what we have now in healthcare. So we set about that by funding Arnie Milstein and his Clinical Excellence Research Center at Stanford. He went into a claims database and he said primary care should be the manager of all care. Let's look at practices that have a total cost of care that is low and a clinical quality as measured by HEDIS measures, health effectiveness measures, in the top quartile. He found a little less than 5% of the practices surveyed, very big commercial database. About 4 to 5% of the practices were at the top quartile in HEDIS, lower quartile in terms of total cost of care. Not just the care that was provided in the primary care physician's office, but the total care provided to the patients that were attributed to that primary care physician. He then went to those practices and identified 10 features that he felt drove that performance, that exemplary performance. And in terms of total cost of care, the average was 25% lower total cost, with some practices with high quality being 50% lower. And they line up with Brent's numbers that he showed you this morning. We then asked ourselves, do we merely support Arnie in his publishing of this data, or do we actually try to replicate the model? And Pete and Michael and their private equity experience said, we're used to actually trying stuff. So let's try this. So we created a capability within the center to take these features, which were really principles, and break them down into what we called future state functions, over 100 future state functions. And then we did a limited market test with 3 practices, one in New York City, one in Missouri, and one in Minnesota, to actually replicate the features. And we were successful in replicating the features. That's the good news. The good news is you don't have to have an IQ of 150 to be one physician in a million to do this stuff. It's about design, it's about process, all the things that you heard today. That's the good news. The bad news is it took 1.5 years. The bad news is that it took $150,000 per unit-based team. And it's not scalable in the way that we did it. And so now we're looking at how do we use software, how do we create a distribution network, how do we find the levers in these 100 future state functions that will be the key to radically improved performance. We know it can happen. It's already happening out in the field. We know it can happen from the perspective of our limited market test. The question is to how do we develop something that's scalable? So the last point that I want to make is this. Radical improvement along the lines of what Brent showed us on his slides and what Elliot and Farzad spoke about is a heavy lift. And it's very easy for people out in the field, leaders in the field, to kind of follow the water downhill. This is not water downhill. This is hard work. It is the work that needs to be done in order for us to flatten the cost curve and to have better quality and better outcomes. Pete and Michael Peterson are committed to this work. They're looking for collaborators to move forward. They realize that transparency along the lines of what Elliot is saying is key as also an incentive to promote this kind of work. So I would say there is a bright future as long as we stay on this target, and we gradually increase the incentives and the sense of risk, because little risk, little reward, little change, bigger risk, bigger reward, bigger change. I'll turn it back to you, Joe.
Thank you, Jeff. I mean, it certainly, raises some interesting questions about how you do it. If you go from a situation where much of medicine is, where financial risk is largely irrelevant, how quickly can you move to the big risk, big reward model, and just how much disruption do you create in that process? It's an interesting question. I wanted to quote something that Brent said earlier, though, that really stuck in my mind, which is, he said that on a daily basis, the health system pulls people back from the brink of death. Mm-hmm. What we're challenged with is pulling people back from the brink of clinical intervention, especially when it's expensive, unnecessary, and potentially harmful. But, that should be easy. That's just management. I think that's what I understood. Anyway, Jim has some comments.
Oh, thank you. Yes, I wasn't planning to speak too long because we have such a distinguished group here, and I certainly want to give everyone, and Joe does too, opportunity to react to what others have said and so on, but I can't help myself. I have a few things I got to say, so I think the first thing to say here is that everything in healthcare, my experience has been everything, as soon as you think you know something in healthcare, something comes along that makes you question something you thought you knew, right? So, for instance, we've been hearing now, I don't mean to start on a too negative a note here, but we've been hearing for a number of years now that some of the policies that put in place in the Affordable Care Act really changed things for the better, really changed the care delivery structure, really changed the cost structure in a way that was positive, bending the cost curve and all that stuff, And then we see a study and one of the key policies was the readmission policy on hospitals. The idea being that hospitals should be penalized if they readmit above a default rate that would be more considered more usual. And it was done top down. The federal government set the standard. Here's what it's going to be. And we heard for 3 or 4 or 5 years from Obama administration officials that this was revolutionary and it was changing everything for the better and so on. And then we get a study that says essentially, well, yeah, maybe save some money, but the mortality rate has gone up. Right? So I think the idea that these things are going to be easy from the federal government's perspective, really needs to be questioned. I think a second thing to take away from Dr. James's presentation, which is really, to my mind, really important to understand, which is the difference between what he described, which of course I view as, very much the gold standard of how to think about driving improvement in clinical practice, how to really do it on the ground in a real practice with physicians and hospitals grappling with all this complexity. But there are two things in it that the vast majority of our delivery system doesn't want to touch because it's hard, expensive, difficult, and may be embarrassing. Okay? Two things. One is, what actually are those unit costs? Those little 6-minute intervals, those little acquisition costs that Brent was mentioning. How do you measure the real input cost to delivering care? Most physicians and most hospitals don't want to know that because they know it would be disastrous to find out because it would show massive waste. Second thing they don't do is they don't collect actual clinical data that they then use to evaluate their own performance. So even in the ACO model, what's happening, a lot of physicians will say, well, I'm in this ACO thing and I'm waiting for the data to come from CMS to tell me how well I'm doing. I mean, that's really not a way to run a clinical practice, right? The idea that you're going to wait for this data download from CMS to tell you how you measure against your peer groups, 6 or 9 or 12 months later, that's never going to work. So people have to actually spend the money to figure out how to collect the data on the patients they just saw to see if they were healthier or not. And, that's a huge, as you can tell from Brent's presentation, that's a huge investment. It takes a lot of work to do this right. And I don't see much evidence that the stuff we've launched is really getting to that kind of level of sophistication. Now, having said that, I think the third thing to note here is that let's not leave Medicare off the hook from all of this. Medicare, on those arrows that Dr. James pointed up, when the ones are pointing down and the ones are pointing up, there's commercial insurers that are involved in pointing in the wrong side of that equation too. But to my mind, there's now agreement. I think it's good, but slow to come to for a long period of time, which is that Medicare fee-for-service combined with Medigap insurance has been the driver of massive waste, fragmentation, lack of coordination in our healthcare delivery system for 30 years, 40 years. And if you want to know the one reason, what is the main underwriter of massive waste and inefficiency? It's Medicare. That's the program that pays for it all, more or less. And so you gotta, and I think the prior administration got it right. They didn't want to say it that way, but the truth is they went to Medicare knowing you would never change the delivery system without changing Medicare too. And so I think there's growing agreement around that, which is good, but long overdue. And then the other thing I'd say here is that the idea, I think that the ACO model, which there is a big place in the Medicare program for provider-led efforts to do what Dr. James is saying. Some room in the program that is not just the insurance model, but a bottom-up, provider-led effort to say we can do care better for this population. So I'm in agreement that we should have that kind of model in the program, maybe taking the ACOs and redoing them or rethinking how do they fit in. But I think there are two things about the way they went about it that just are problematic and have to be changed. Number one, this idea of attribution. The idea being that, that the Medicare patient shouldn't really know what's going on. We're just going to take claims data, place them into these ACOs, don't really tell them, maybe, in some obscure way, send them a letter that they never read saying they're in it, without really telling them what it means or anything else. And then, assume that ACO is going to be able to do population-based health care based on a bunch of patients that have no idea they're in it. Never signed up. And they did it because there's two things. I think this was sort of like, they didn't want the ACO model to be they didn't want to build a new competitive model in the Medicare program. They wanted ACOs to be a better way of managing Medicare fee-for-service without really having to tell anybody or without having to compete with Medicare Advantage. And I don't think that's the way to do this. I mean, I think if you want to drive efficiency in it, and the other problem I just would say is that it was very top-down instead of bottom-up. Again, back to this notion of who's collecting the data to make this better over time. The ACO model is relying entirely on, a lot of them are relying entirely on the federal government to send them data about how well they're doing. I just find that impossible that will ever work over time. So what to do about all this? It's a complicated situation, obviously, but I would say that some things that Joe and I have written in recently, I would suggest to think about how to make this work in Medicare so it does drive more competition in the marketplace, but it's a fair competition between the capitated program that already exists in Medicare, Medicare Advantage, where if you get it right, the incentives could be very good for driving the kinds of investments that Brent has talked about. Have that compete fairly with ACOs and with unmanaged fee-for-service. So if someone wants to stay in an unmanaged, fee-for-service program where they pay for anything and nobody's watching anything, they can go into that, but it costs them more money. If they want to go into an ACO that maybe is doing some risk sharing and is, saving some money through that, perhaps the beneficiary shares in the savings. One of the ironies of the Medicare Shared Savings Program is the savings was shared between doctors, hospitals, and the federal government, right? The patient didn't get anything, right? So if there's any savings to be had, the patient was totally left out of it. So that's not really the way a market works. And so if you want to get the incentives right, the person who's making the choice, affected the most by it, needs to save some money too. And you got to build that into the choice structure of the Medicare program. So I just urge some thinking about how to make this different going forward, because where we are now, yes, there's been some modest progress here or there, but in terms of the challenge that Dr. Brent has laid out, I don't think we're anywhere close yet.
Okay, thank you. It does raise the question of what is the role of the patient, other than, of course, to sit in a little room and wait for the doctor to show up. Is the patient a purchaser? Is the patient a consumer? Is the patient just a patient? or is the patient just a beneficiary? I mean, it's very hard to know what the role is, and I don't think that's part of our problem. We really haven't decided what does a Medicare beneficiary's role in this system is. I think it stems back from, frankly, decades ago. Healthcare was, in my parents' generation, healthcare was that if you had to go to the doctor told you to do something, you said yes. It was always sir, of course, and then you might have done it, you might not have, but it was kind of one-way communication. And the idea of making choices or having choices, having information was completely unknown, I think, to certainly my parents' generation. To my generation, the theory of having choices and getting information is certainly there. The theory, not the fact. I'm hoping that maybe our kids will have the fact. Anyway, why don't we have a little discussion among the panelists? I have a feeling that someone may have said something that someone else might have objected to.
Well, can I jump in on the choice and,
Yeah.
and patient's engagement here? I think it's fundamental, and I got a little bit of it with my story about my father. The notion that the really high-stakes choices, yes, your insurance product is an important choice, but the really high-stake choices are around what procedures you're going to get and whether they're a benefit or not. So if you take one example, recently in the Lancet, we do stents, when all those little cute tubes. I won't ask how many people have them in their coronary arteries. They are life-saving in the context of a heart attack. There are 500,000 of them done around the world in the setting of stable angina. That is, we all believed they improved your chest pain. 90% of patients undergoing an elective stent, believed it improved their survival, reduced the risk of heart attack. It does not. It's a choice. Whether to have it, there's some risks and trade-offs. Well, it turns out from the Lancet article 2 weeks ago, if you compare it to a sham procedure, there's no gain in symptoms compared to the sham procedure. So this is a really, really expensive and dangerous placebo, prescribed by physicians to patients who are unwittingly receiving these procedures. So there are tons of high-stakes procedures. So I'd say we want to both create, and I love the idea, let's create good choices around benefits, around what plans do you want to be in. I think I think exchanges, some of them, California Exchange has done some good work on structuring choices so that patients can compare apples to apples about what plan they want, and they're really having to compete on price. But we also have to align delivery for reform with benefit design so you don't kill the possibility of primary care delivering better care. So I think I'm completely on the consumer choice side of this, and how do we get there from here? Structuring insurance choices, annual choices of what plan you want to be in is one, and we ought to make awfully sure that patients are making wise choices about what really is important to them in terms of their goals.
Joe, the key feature in these exemplary primary care practices was something called shared decision-making, where the team, not just the physician, but the team engaged the patient in what Elliot is talking about. Here are the options. Let's talk about what's best for you. So I think that's key. To your question or your response in terms of how fast, I think what we find is, and it's easy to say, it's a process. How do you synchronize policy and practice? If policy's too far out in front, not going to work. If you've got practice way out here, but you don't have the incentives right, it's going to fall apart. So how do you bring these two out together?
Let me add some of that practice, goodness in here. So we're actually operating 20 ACOs, right? We're in the field running these programs, and just a few words about that. One, the patients don't feel that they're now being cared by some new thing that's an ACO. The patients feel like their primary care doctor is giving them better care now. They're now calling them after they leave the hospital. They now provide them with access, and now when they call, they reach somebody, right? So I actually feel like that's the right thing, right? Like the right thing is not to introduce some new foreign concept to the patients. And when, a couple of years ago, there was that requirement that we send them, the patients, the letter, like they uniformly were like befuddled and confused as to like, who the heck, what are you even talking about, right? So I don't think introducing a new mandate that there be a new identification and like like check some box on, patients now being informed, around this. My practices in Arkansas and West Virginia and Mississippi and Louisiana are going to feel like, here we go, more paperwork that I need to get someone now to sign some form. That is not true engagement. And I don't think it fundamentally changes anything other than imposes more administrative burden, well-intentioned. And one more example of hey, look, I rolled out meaningful use, so I know from this, right? Well-intentioned, whole set of administrative burdens that end up becoming a compliance exercise. The other thing to Jim's point, we don't rely just on 9 months later claims data. We're pulling real-time data out of electronic health records, practice management systems, scheduling systems, admission, discharge, transfer, HIE fees every single day, because that's what you need to be able to do to manage that care prospectively.
I think that's exactly right. I think the question is, in my mind, how many ACOs have that capability? You said 20.
We're managing 20.
Right.
A growing number that do.
But
I think
it's
set
a
the
huge
incentive.
it's a huge investment,
A
and it
huge
also
investment.
requires a change in the way you think about this. It's not just you checked off a bunch of boxes, you never looked at the medical record again, and you couldn't understand it if you did. It has to be completely different from what we're doing now, right?
Could I just emphasize something on that grounds? Twice at IOM, we studied the concept of transparency. I don't think we ever published a specific report around it. Turns out that almost all clinical decision-making takes place in the context of a clinical team or a physician interacting with the patient. Right. This idea of clinician-patient relationship turns out to be absolutely central to this whole thing. When I hear about shared decision-making, it's a transparency issue. You do realize that today, about 80% of all information captured in a clinical environment is not computable. It's not truly digital data. It's unstructured free text. Most of the data that we get back from groups like CMS or major insurers are actually repurposed financial data. Okay. And it lacks the clinical data detail necessary to really create a transparent environment. Most clinicians do not understand how their actions link to outcomes on a regular basis. Twice we came back and said that's what transparency means. We have another fairly strong evidence base that shows that most patients don't pay any attention to league tables, to rankings of providers when choosing a physician or a hospital. 2 or 3% do. That's what the evidence shows. The vast majority rely upon that relationship as a purpose. I think the one rising tide that would lift all ships is far better transparency in care delivery. And it means that we'd have to fundamentally understand in a different way what we mean by transparency and how we deploy it. Our current data systems for transparency are pretty much completely inadequate for what we have in mind.
The exemplary practices that Arnie Milstein identified didn't know they were exemplary, either in cost or quality.
Meaning what? That they thought this was normal practice.
Yeah. They had no idea that they were high performers.
Yeah. It's fascinating.
I think all physician practices think they're high performers.
Oh, you're right. Lake will be.
And making the invisible visible does stimulate the kind of curiosity on the part of health professionals about how they could do better.
Can I add another thing to it? I've been doing this for the last 30 years. When you're dealing with clinicians, there's a flame that burns in their heart, for lack of a better term. We select for and then train to very deeply to put patient needs first. I will agree that on rare occasion, it's quite rare, you do get true sociopaths. My joke is to say what you will about the healing professions, we're really good at weeding out the sociopaths. The vast majority of them honestly believe that what they're doing does benefit patients. We've shown repeatedly, time and time again, that incentive is dramatically more important than financial incentives. It's nice when they align.
Well, it's actually Michael McWilliams and my hypothesis about why we're seeing anything happen with ACOs.
Yeah.
Imagine such weak incentives, such confusing mess. What we think is happening is that it's unleashing the intrinsic motivation that the folks who are in ACO, the physicians who are working in these organizations, came to the day job with, and this allows them to try to make care better.
That's the story of my professional life. I didn't need to improve their intelligence. I didn't need to improve their work ethic. I didn't need to improve their dedication to patients. Every time I made it more transparent, down at the level of real practice, care improved. And my colleagues routinely stepped up, even the wild naysayers, the guys who appeared to be in it completely for money. Jack showed that originally with, remember his old TERP data? That's a repeat finding in that literature if you look for it. And I think that sometimes we miss our most important lever. Centers around transparency and taking advantage of the professions, the healing professions in general, deep commitment to patient outcomes.
In conjunction with realigned financial incentives.
Incentives would help.
It's good when the incentives align. It's good when the incentives align.
It makes it easier.
You know, one of the things we found in our spread or dissemination efforts is I have to admit, I was coming in with a fair amount of judgment in the beginning as to how we were going to move this thing forward. What we realized, again, in the exemplary practices, that probably the most important thing was the level of engagement of the clinicians themselves. Very high. And so now we've thought of our dissemination effort or replication effort more in terms of how can we describe this level of engagement potential, because that appears to be the piece, the catalyst in terms of the spread.
Yeah, I just want to jump in again back to this question that Farzad reacted to about the beneficiaries' participation and knowing sort of that they're in the ACO, or how does that come about and what are the implications of that? I guess the one thing I'd say here is that there's probably a difference of point of view about what is going to be the fundamental driver of ongoing productivity improvement in healthcare. I think the notion that, from my perspective, it really is the notion that the financial incentives will be set up so that a plan could make more money, do better, by lowering their costs and attracting more market share and having a bigger enrollment in their program over time, which would involve the beneficiary selecting that option, as opposed to the alternative option, which is, I think the way the ACO thing was rolled out and still is this is a newer, better way for CMS to try to manage fee-for-service Medicare. That is, we're going to try to move away from unmanaged fee-for-service. We're going to have this ACOs. We're going to put all the beneficiaries in it. You know, this the alternative payment model. It's the way to get away from, paying for volume, paying to value, and we're going to drive productivity improvement by sort of regulating that approach to delivering care in a way that's fundamentally different from the way we did fee-for-service. And I think those are the two ways of thinking about ACOs. Is it something that should be competing with MA plans for enrollment and beneficiary loyalty to getting their care in that form? Or is it something that should be used by the government to try to manage fee-for-service better, basically?
I guess, Jim, I'd say I love that idea of creating, this is a new thing. That's not like, I think the ACOs, largely you're right, is to be an alternative to fee-for-service. But I love the idea of creating kind of like super ACO incentives that would compete with Medicare Advantage. And Joe was saying like, well, how do you set the baseline? Like, I'll take MA premium rates.
Yeah,
Give me that, right? And fix the ACA.
As long as we get rid of the upcoding, yeah.
So let's
Hey,
just
do the
clear-
same thing.
let's-
Let us compete.
can
Let us
do that.
compete with MA.
Let's be clear, Farzad. All that we're doing in this, it's the next gen ACO. All that we're doing is taking the insurer out of the middle, where
Yeah.
the practice bears direct financial risk.
And you can tell the patients.
And well, we spent a day. Don Berwick and Rick Fillon came out and spent a day with us. Do you realize that almost no integrated delivery systems went into the ACO model initially? One of our primary issues was this idea that you're slamming your patients without their permission into this managed care environment. State where I live, if they'd figured that out, it would have been a political bloodbath for us, given the nature of the state where I live. That just seems wrong to do that to people, and we thought it was fairly important. Of course, they were very worried that would somehow risk select. That's what their real concern was, and the government is would somehow use this to risk select.
No, I think-
We said any measure, anything you'd like to have, but our patients need to know what we're doing and why, and they need to of their own free will and choice. We think we can market it pretty well. What you're doing though with these is it's basically an MA plan, but you take the insurer out of the middle, which, by the way, was Next Gen ACO, and it's not a bad idea. If a group could take that kind of risk, I think it's a pretty good card to remodel.
With a better baseline.
Yeah.
Although, on the baseline thing, make it more generous and then use a progressive income tax. Then we don't have to fight about it as much. We just get to see how much savings they achieved, and if you achieve 20%, just give 18% back to the feds or to the patients.
Elliot,
Sorry about that. I sat in a smoke-filled room in California.
You inhaled.
I sat in a smoke-filled room in California with a bunch of
Kill the incentives.
with a bunch of guys yes, exactly, a bunch of guys who were so furious that the initial model of the ACO was going to cap savings at 15%, because they knew they could make so much more than that. So I think there's something about sharing with the beneficiaries and with the federal government. And so a progressive income tax would have been a way to solve this whole benchmark thing
Elliot,
to
when
begin with.
ACO started, I would hear the term capitation light. Was the ACO design a recognition that neither the public nor providers were in a position to accept risk?
Do you remember when there was this thing called managed care?
Yeah.
And so we were doing all we could to try to come up with a transition toward, bearing some risk and having the incentives to reduce costs and improve care. In a world where, some MA plans were doing okay, but everybody vividly remembered the managed care backlash and choice and non-attribution, all this attribution stuff was, our good colleague John Rother over there, AARP would not have signed on. The consumer groups would not have signed on if we locked people into something that scared them, and it would have required a change in the Part B benefit, which we couldn't pull off. That would have been a really heavy lift in Congress. So I think it started us directionally toward where you want to go. And I'd love to see more flavors emerge. It was clearly, on Mark's and my point and others who were involved in this is a transition to get us toward capitation, which we know is the way that's going to have organizations willing to change and care possibly getting better. We haven't mentioned measurement, which we really should talk about how performance, what we could do to make the measures better and do risk adjustment better. That's another opportunity for good collaborative work.
Okay, Joe, can I ask you a question?
Yeah.
Competition. So how do we make markets work when the local market becomes highly consolidated?
Well, that's a darn good question, and your reference to the Brookings paper, unfortunately, doesn't really answer it. The ham-handed and largely impotent approach of the legal approach of trying to stop mergers, of course, ignores the fact that it already happened, so it's too late, and also ignores the fact that that's really not the mechanism by which markets are dominated anyway. And then by the same token, an awful lot of talk from a Republican congressman about, and others as well, but Republican congressmen in particular, about having competition among insurers, missing the point that if you're in Boston, there is a hospital that you're going to have in your plan no matter what. And all the other hospitals know that, and they know pretty much how to price it.
So what is one of the costs, the reasons why prices and costs have been going up so much is because of that consolidation. Yeah. So what would be the market prescription for that for this new administration?
Oh God. The new administration, I'm not sure. I think Elliot has an answer.
No. Well, I don't know. It's, my brother's a finance guy who tells me about how other capital-intensive industries work, and they separate the delivery from the ownership of the capital-intensive structure, so airplanes and hotels. So why don't we separate hospitals from physicians? And then we have physicians, lease the beds and compete, so that would serve you very well. And hospitals become either a regulated utility or some other way of managing that really wasteful infrastructure or you think about a regulatory model, maybe there's competition, or maybe we have a cap and trade program for hospital beds if you want. If Mass General wants more hospital beds, they have to buy them from someplace else, and they can't monopoly price anymore because their physician group has been separated from them.
Well, the one thing we know for sure is that the certificate of need, which was supposed to do something like that certainly didn't work.
That's why the cap and trade, it's a market. Yeah. Let's have a market do this thing.
But I think your point that hospitals especially by buying up physician practices and specialty practices, means that since their primary incentive, the easy money, is fill the beds.
Exactly.
We're sort of trapped in that methodology.
Let's change this.
Yeah.
Everyone at this table, we can get it fixed. Everyone out there.
Well,
I believe none of us have ownership stakes in hospitals, though, so.
Nope.
let me just say one
Yeah.
thing about that. In terms of what to do about it, where is it
We'll get
going?
to it.
I mean, the policy levers are weak. I pull whatever ones we can. But I guess I would say, and people have been predicting this for a long time, but I do think, I mean, it's not really the greatest bet in the world to if you were looking at putting money down, I'm going to assume that our nation's inpatient system of caring for patients in 2035, for instance, is going to be basically like it is today. I mean, it looks the same as it does now that it does 25 years ago, but I mean, really, we're at the point now where one could see a system being built where their reliance on inpatient admissions is 30% of what they are today. And so the creative destruction, so to speak, someone will get a hold of it. I don't know who, when, where, how, but the health plan that builds itself to have 20% of the admissions of somebody else because you don't really need them, they're going to make huge amounts of money.
That's the basic strategy that the big for-profit insurers are describing. Their classic example is Hill Physician in Northern Cal. So it's 1,200 physicians roughly in an IPA model plan, so they weren't even a single business. But they had this IPA model where they collaborated, became very good at upstream management of care. And they were capitated. They did really well financially, and they basically took it out of the height of the hospitals. Is where they were taking the waste out, but then they harvested the value back, you see. And so that's the whole strategy that those big for-profits, they're not buying hospitals. They're buying
Jeff has
primary
something
care.
else to say.
Well, we just funded a study that was published in JAMA by the Institute for Health Metrics and Evaluation, and what they showed in terms of decomposing the healthcare spend over the past 16 years is that the reduction of inpatient days in hospitals is 46%, and yet the total spend for hospital inpatient care has gone up.
That's right.
Only second to pharma's increase in spend. So I think what's going on is lesser volume, price up to make the difference. So how do you deal with
Higher
that?
quality, obviously, the price
And
goes up,
also-
the quality goes up.
And also more and more of the Medicare inflation has been around hospital outpatient departments.
Yes.
So they're coming out of inpatient, but now we're charging 3 times as much for everything else going on in the hospital outpatient department. The other thing I just want to, I wouldn't be so sure that the regulatory lock-in and the market lock-in that they have is not going to withstand the disruptors. If you want to start a new insurance company, and we just went through with a partner doing a JV in a local market trying to set up a new health plan, if that hospital doesn't sign the contract with you for not just the hospital, but all their specialists, you're dead.
Yeah.
You do not have a new health plan if that hospital doesn't want you to have a new health plan in that market. So I think we got to, pull all the policy levers, but also think a little harder around what are the policies that we're doing that are actually encouraging this.
Yeah, very good. Well, I think it may be time for questions. Would you wait for the microphone, please? Identify yourself and be sure to ask a question.
Hi, my name is Barbara Dello. I was a long-term care nurse for a long time, and I just spent the past 6 years taking care of my dad, who moved from a fee from service to what I believe was an ACO. And I have to tell you, just in his particular experience, in my experience, it wasn't quite so rosy. There was less hospital and more home-based care, but most of the care and responsibilities was in the hands of poorly educated and poorly paid home health aides or me, exhausted family. More decisions. There was the nurse care manager, and she made most of the decisions, and there was very little interaction with an MD. And the social worker's role, in his case in particular, was to achieve comfort with more conservative end-of-life choices. So I could see where there would be good cost savings, but my question, I guess, is about balancing the downgrading of care with the cost saving. And if I could also just say, I get a little frightened when you said about risk versus benefit, because you'd like to think it has to do with preventing foolish procedures by greedy doctors. But does percentage of success or poor prognosis also factor into what's considered poor benefit?
Those are wonderful questions and challenges that the model really faces, but almost as to many managed care plans. It's the challenges, are we measuring what's really important to patients and rewarding systems for delivering much really better care, and that then achieves savings, as Brent was describing, through delivery of better care. I think one of the, we've mentioned this arcane topic of upcoding up here and the risk adjustment that MA plans face. And Brent has talked about the importance of really measuring clinically important data. There is, it's easy, actually, a little expensive, but easy to measure health outcomes and really measure functional status and how patients are really doing. There are also some wonderful measures that let us understand whether, with very short survey items, that let us understand whether patients are having their goals met, whether the clinicians are paying attention to what's really important to the patient. One of those measures developed by a colleague called Collaborate, 3 items, around what's important. Did they ask what's important to you? Did they help you understand your treatment choices? And did they make a care plan that was aligned with your preferences? So if we think about a new measurement system that would support primary care physicians in really doing a great job, or specialists, because it can easily be integrated into disease-specific functional status and outcome measures that are related to whether you have inflammatory bowel disease. I think we could move to a new measurement system that's really good for risk adjustment, so they wouldn't be rewarded for upcoding, and would do what Brent wrote about 25 years ago. That is, let's use measurements that are used for improvement as the foundation of a measurement system that's built for accountability, because then it would do both and do it well, and you wouldn't have been harmed.
I just want to say, thank you for raising the question. Thank you for what you're doing for your dad. I mean, this is so hard, and all of us are thinking about this for ourselves, right? We have to meet that challenge. We have to make sure that people understand that this is not less, that it's more. That people have more access to their physicians, not less. That they have more support, not less. Because, as has been mentioned a few times now, we already had a backlash once against people feeling like the system is saving money on the backs of patients, and America's not going to stand for that. So we really do have to meet that test. And I am concerned. There are some people who, even the docs don't know they're in an ACO. Right? Because some big group says we're an ACO, and then they sprinkle some care management on top of it and some social workers, right? It's not really fundamental transformation.
So I want to second what Farsight said. Thank you for raising the issue. The measurement is very, very important. What's equally important is that when you change how care is going to be provided, you need to design it. And I'll put in a plug for Brent. I went to his advanced training program in the early 2000s, and it is a science. It is a process, and it takes time to master it. But you have to design the process of care in order to improve the care and reduce the cost. What I get concerned about is that process not happening, and costs are simply taken out without a design. And so I think the importance is for us to think about how we can bring design capability into these care processes. And that's what I learned, Brent, in the ATP program, that you barely passed me.
Next question. This gentleman here.
Hi, thanks very much. I'm James Class from Gilead Sciences, and I wanted to first of all, thank you all, and Dr. James especially. I like the framework very much. And I noticed that when I was listening to it, I was really thinking of it with a lens of chronic disease, right? And of course, that's been under discussion. But there's also some very new, exciting stuff we all see in the press, even coming out from FPA now, about curative therapies, or pretty close to curative therapies. HCV speaks for itself. There's some newer things in oncology, gene therapy. A lot of this is really kind of pushing some boundaries. And I wonder, just first of all, Dr. James, how you think about that from your framework point of view, because when I saw that, I thought, oh, there might be a component that's in the genetic part, there might be some that's in the treatment part. But then I think what I'd love to hear about from the rest of the panel too is how do we start thinking about this from the incentives point of view? Because if you get, full 100%, I mean, God willing, patient outcomes, you get the outcomes that you want in a relatively short period of time. Someone also pays in a relatively short period of time, but the economic benefits accrue across a long period of time. Well, at least in the United States, the incentives aren't going to be clear because a patient could be here and could be there and anywhere. And I certainly don't expect that there's an easy solution, but I'd love to understand your thinking about that and what kind of conversations we need to have.
One of the tools for this is purely analytic, believe it or not, and I argue that you have to think about it across the full continuum. As a system, you certainly do. We had a benefit that we had a very high degree of patient loyalty. We knew we were going to get them eventually one way or another, so this idea of on a quarterly basis looking at your turnover rates just didn't make any sense at all. It was just stupid. I actually built the business plan when we launched our precision medicine initiative down in St. George, Utah, of all crazy places, fresh out of Stanford, brand new graduate in genetic sequencing for cancer treatment. Turns out that the core of that business model, and our local administration couldn't do it, but they came seeking some help. I used decision analysis, which was great fun. Turns out that you were identifying patients that you knew would fail initial courses of chemotherapy. Of course, the chemotherapy will cost somewhere between about $150,000, $450,000, depending upon how bad you nadir their white count and stick them in the hospital a few times. It's putting them through hell a little bit, but you could predict who would fail. Chemotherapy, missing 1 or 2 or sometimes 3 courses of ineffective chemotherapy, far more than paid for a $10,000 per month drug, believe it or not. That was a net cost savings. One of the hard things down through the years I've tried to do is get not just care delivery groups, but also big pharma drug manufacturers, device manufacturers, to think in terms of a process of care, not a single product. So when you do, it gives you a whole new way of examining what works and what doesn't. Now, Deming's core theory, there are 3 ways that what he called physical outcomes, clinical outcomes, interact with cost outcomes. By the way, quality describes the attributes of an outcome. And Deming made the point that all processes produce 3 parallel classes of outcomes: a physical outcome, a cost outcome, and what he called a service outcome. So the experience piece, as the interaction takes place. He then explored how they interact, and he identified 3 specific mechanisms by which your physical outcomes, in this case clinical outcomes, directly drive, they're causal. And he used that to demonstrate for 2 of the 3, that's where the waste definitions actually come from. For 2 of the 3, as you improve your physical outcomes, it causes, causal, your cost of operations to fall, all right? It was basically a mathematical proof. And guys, it doesn't get much better than that. The 3rd category, or higher quality, costs more. Interestingly, he hadn't named it. It's what we would call cost effectiveness in healthcare, so stuck a name on it and working with him. The main takeaway is in that circumstance, you have to ask the people you're serving how they value it. It's no longer my decision. Given the size of the benefit that we expect, is it worth it in terms of the resources that it will consume? So you have to have a mechanism for asking those who will pay the money and get the benefit. Well, wait a minute, we're back to shared decision making.
At a community level.
At a community level. So we have mechanisms for dealing with it. The point is the first 2 big categories, 50%. General consensus, if we eliminate the waste, it makes that other class of decisions easier.
No kidding.
And there's a moral imperative. We have to take the waste out.
Yep. Couldn't say it better.
Yeah, right here.
Lou Gagliano, healthcare consultant. Hospitals have reacted to many of what the CMS regulations are, and they have changed their practices. And I think the important point of that goes back to this question on incentives, particularly for ACOs. And I haven't seen any study that has really taken into account the credit that ACOs should get for keeping people from having epic events where they wind up in a hospital. So the real question here is in the short term, because hospitals did react to readmissions in the short term. Hospitals have reacted to infection rates in the short term, the ones that realize they have a problem. So where does the incentive come from to pay for some of these long-term benefits? Who pays for it? Because that's a key question as to whether this long-term ACO concept will really run its course.
I mean, I think the data show, Elliot can correct me if I'm wrong, that hospital ACOs reduced mostly post-acute costs, and physician-led ACOs reduced actual hospital utilization and post-acute costs. Downstream, right? So the question is like, who's downstream of me, right? So that's been the biggest emphasis for hospital ACOs has been and on bundles as well, has been not on reducing the number of admissions, but on actually, squeezing someone downstream from them. And so the more people you have downstream of you, the more effective I think you can be in reducing those costs.
Something about financial incentives.
You might not call it squeezing, though. It might be good for the patient.
It nearly always is good for
Yeah,
the patient.
right,
It is
exactly.
good for the patient.
Exactly.
I mean,
I think that's why primary care has such leverage.
Well,
yeah, no, it's
primary care, but not
Well-designed
just primary care
population
doctors.
health, too.
It's whoever your primary care doctor really is. So if you have a heart condition, it's probably your cardiologist.
not necessarily.
But no. But what I'm saying is, it's not just one narrow definition of who a physician is.
You'd like
Yeah,
the primary.
it's a care team.
Yeah.
Agreed.
I think, have we done it? One more. Thank you.
I'm Dave Houston. I work for Optum. So most Americans are still covered by a first dollar coverage plan, and you guys kept bringing up consumer choices and transparency. We're moving away from first dollar coverage, so if we got away from that model faster, wouldn't that force to the front both consumer choices and transparency?
Depends. Well, I think you will high deductible plans that are not trying to distinguish between between primary care and other services can destroy any attempt to do the kinds of reforms that we're talking about. So if you align benefit design with delivery reform, I think you can make substantial progress. So the California Exchange requires all plans offered in covered California to provide pretty highly subsidized primary care, and then imposes the choice and the financial burden on those subsequent choices where the consumers really can choose wisely. Don't get an unnecessary MRI. For heaven's sake, if you're going to get back surgery at a time where we know that most back surgery is harmful, by the way, here's some financial incentives to make you pay attention to that choice. So recognizing the places where it's wise to have consumers make choice and where we need to have physician teams make those choices, like when you're really, really sick, none of us are going to be saying, hey, which kind of ICU am I going to? We're not going to be making those choices. Our physician teams and our clinical teams are going to make those choices. So I'm completely with these guys on structuring consumer choice, and let's structure it wisely.
Is it Mark Vendrick at University of Michigan that talks about this nuanced approach to deductibles, just along the lines of what you're talking about?
But it's not just that. It's not just the financial incentives. It's also the confidence in the physician. So Walmart has a very good program for spine surgery, which consists of sending the patient to an eminent center where most of the time the expert says, no, you don't need back surgery. You need physical therapy. That saves an enormous amount of money, and it also relieves harm, and also relieves the patient of having to figure out what to do.
Yeah, no,
Well, anyway,
we could do this.
on that uplifting note, please join me in thanking our panel for an interesting discussion.
Thank you, guys.
Doing great work.
Actually talk to Michael.